and a happy rainy day. I'm sure that this is not a very suitable time for this lecture because you must be thinking to go somewhere to enjoy your meal. But anyhow, this is what we have to do because syllabus has to be completed. Just a small change in the program because this lecture is to be taken by the UNT people, but because of certain commitments, I'm here. I'm a man of psychiatry, Dr. Qadar Tawfiq, and we'll be talking about anxiety spectrum disorders this afternoon. Now, anxiety spectrum disorders and obsessive compulsive disorder as well, which is a part of anxiety disorder. As a medical person, I think that it's always good to know everything about everything. But since it is not possible, certainly, so we cannot know much about the other disciplines. But when it comes to anxiety specifically, I think that it is a little more important in comparison to other fields of medicine that everybody should know and everybody should understand the concept of anxiety at least and the handling of anxiety. Because it is irrespective whether you are a physician or an ENT person or a general practitioner or a surgeon, but whenever the patient comes to you, he has some element of anxiety, may not be disorder, but anxiety. And so you have to have an idea of this particular disorder or disability of the patient. We have certain learning objectives for this particular lecture, and by the end of this lecture, we should be able to define, differentiate between physiological and pathological anxiety, and list the clinical features of anxiety. We have to differentiate between different types of anxiety disorders, hyperventilation, which is a very common happening in our ERs, and we should know a little bit about the etiology and broad lines of management. Obviously, we are not expecting you to manage the anxiety disorder, which is a bit difficult bit difficult thing to manage on the part of psychiatrists as well, but to identify and to have some idea of management of anxiety disorders. This is one of the important learning objective of this particular lecture. Now, what is anxiety? It's a diffuse, unpleasant, obviously unpleasant, vague sense of apprehension. How we identify? Because it is always accompanied by certain features, certain clinical features, and most of the clinical features are basically autonomic symptoms. And what I mean by diffuse, that we cannot locate from where it is coming. We cannot locate what exactly the source of anxiety. And that is why it is vague and diffuse. Obviously, it has to be unpleasant, only then it is to be called as anxiety. At this particular point, it's very important to differentiate between stress and anxiety. Although the clinical manifestations, the disability, the sufferings are by and large same, but stress is not diffuse. Stress is particular, specific. It's not vague. You know what you are going through, what specific stress you are going through. Are you afraid of something to pending happening to or examination stress, for example, of some big misfortune? But in anxiety, you are not able to locate from where it is coming. And so it is, in the second line I mentioned, that it is a response to an imprecise or unknown threat. Now here you can differentiate between the two, that stress is always known. It's precise, it's specific, not diffuse. And the third point is normal response. So what I mean by the normal response, that all the anxieties, all the apprehensions are not pathological. Certain amount of anxiety, certain amount of to be apprehended, to have some apprehension is essential for your motivation to accomplish a task, otherwise you will not be able to do anything. Now, what differentiates between normal and abnormal is that whether it is making you more functional or it is making you dysfunctional. Whether it is making you more organized or you're becoming more disturbed, out of focus, disorganized. So certain amount of anxiety, which is called the physiological or normal anxiety, is important for your performance. And if it exceeds the limit in any, with respect to the severity of symptoms or with respect to the time, it becomes pathological or disease anxiety. So abnormal when its severity is out of proportion. Another important point that it should be out of proportion as well. The threat is small, but the response is too big. Again, it will be called as anxiety. Now, again, a very important point to differentiate. Initially, we got to know about that what is the difference between stress and anxiety, what is the difference between physiological anxiety and pathological anxiety, and now another differentiation that what is a fear and what is anxiety. Again, it is an emotional response. Anxiety is also an emotional response. But here, the source of stress or the source which is creating fear is known, is definite, is external, non-conflictual. Now, with this definition, you might ask that then what is the difference between fear and stress? Because stress is also an emotional response, known, as I told you earlier, it's always in the outside your body, definite, specific. But stress and the response of stress determines, and say for example, fear. And take example of examination. Now, everybody would be fearful of a snake. Everybody would be fearful of a bomb blast. And you will obviously try to escape from that particular situation. But would everybody escape from the examination system or examination hall? No. So here the point of non-conflictual threat arises, and there's a clarification that everybody is not scared that much of examination hall in comparison to that everybody is scared of a bomb blast or a snake or something which is known to be dreadful, which is known to be potentially fatal for everybody. It's non-conflictual. So fear is similar to anxiety, except that fear is against a specific object. This is here we differentiate between diffuse and specific. So fear is always specific but non-conflictual. Anxiety, diffuse, conflictual, physiological, pathological. So I think that you have to differentiate between stress, fear, anxiety, physiological anxiety, and pathological anxiety. And I hope that these 3 or 4 points are very clear to you. Can you raise your hands to show me that these points are clear to you? Good. So let us proceed. How to identify? There are certain psychological responses which are always of arouse against the depression, because in depression one becomes very lethargic, anti-arousal you can say. So worrying thoughts, irritability, one becomes restless, poor concentration, more sensitive to the noise, and the last dotted line means that anything else you can think of. The thing which I really missed purposely, that one of the very important symptom of psychological arousal is sleep disturbance, lack of sleep, insomnia. Then coming to the muscle tensions, tremors, you must have come across defined tremors of an anxiety patient. Different body aches, headache is quite common, but that is also not that not that uncommon. After the psychological arousal symptoms and muscle tension, we can go to the hyperventilation, which is a very common presentation in our ERs of panic disorder patients, anxiety patients. Accompanied hyperventilation means that shallow breathing and rapid breathing. And feeling of breathlessness that he thinks and he feels that he will not be able to breathe. And that impending sort of choking will bring him to the ER every now and then. And if the patient is coming very frequently to ER or to the doctors with these complaints of tachypnea and shallow breathing, and especially shallow breathing means that the patient feels it difficult to inhale, not to exhale. And because of this shallow breathing, because of this rapid breathing, tachypnea, because of the physiological changes inside the blood, the tingling in extremities and dizziness. Initially, we already talked about insomnia, which is one of the manifestations of psychological arousal. Insomnia is one of the important features. Night terrors. Night terrors are basically those terrifying dreams that make you awake in the middle of the night with something which is very, very, very dreadful dream you were experiencing through, but you have no memory for that particular thing. Mostly, it's more of a detailed psychiatry that there is a difference between night terrors and nightmares. But say we are talking about anxiety, so night terrors are fearful dreams in the middle of night which make you awake. When we are talking about anxiety, and when I was a student of psychiatry, and my teacher was teaching me psychiatry and anxiety, he told me a very important point. He said, did you name any symptom regarding any system of the body? And that could be a symptom of anxiety. It does not mean that if somebody is having a chest problem or chest pain, you will immediately say that he is having anxiety. No. But what I mean to say that the list of anxiety symptoms which we are discussing right now are by no means complete. The anxiety patient can complain of anything. So in the gastrointestinal symptoms system, the dryness of mouth, the difficulty in swallowing, epigastric discomfort, and this epigastric discomfort, dyspeptic symptoms, symptoms of acidity, symptoms of loose motions, hurried intestine and bowel, nauseating feelings, sometimes vomiting, and again a long list of GIT symptoms. And I think in these days, when we are sitting in our psychiatric OPDs, very commonly, very, very frequently, we see these GIT symptoms and the patients with anxiety syndrome and anxiety disorders, mainly predominantly presenting with GIT symptoms. And if you go to the GIT OPD, I think you will appreciate that many of the GIT patients, they are having some sort of anxiety as well. And most of the prescriptions of GIT people, they do contain some anxiolytic medicines as well. So what I mean to say that we are talking about the anxiety symptoms, name any symptom regarding even the gas GIT, that could be a symptom of anxiety. Talking about respiratory symptoms, constriction in chest, choking sensations, difficult inhaling, and obviously other common symptoms are hiccups. Cough is a very common symptom when we are talking about respiratory symptoms. And during the examination system, you might have experienced that you're coughing a little more frequently. So this could be one of the symptoms of anxiety. Coming to the cardiovascular palpitation, the feeling of heartbeat, discomfort in the chest, fear of heart attack, tachycardia, more obviously when there is anxiety and there is an autonomic hyperactivity, the heart rate would also be increased. Pulse rate would also be increased. Extremities will be more cool and cold. Perspiration will be more. And there's an impending fear of heart attack. And that is why Again, when you go to your medical ward and you will go to the ER, you will see not infrequently that the people are coming to with all these classical symptoms of, say, for example, heart attack, impending heart attack, ending up and having no problem with the heart and ending up with the people of with psychiatry. But the important thing is this, that if somebody is coming very frequently or once a month or twice a month to the ER with all the investigations done, having palpitation all the time, having the similar clinical symptoms, and especially when the age is not that much vulnerable for the cardiac issues, then you must please scratch your head for that the patient might be suffering from anxiety disorder. Coming to the genital urinary, frequent or urgent micturations. In cases of male, the male impotency means the erectile dysfunctions, and the premature ejaculation as well. The menstrual discomfort in cases of females. And again, the dotted line shows that this is not complete. You can name any other symptom. You can learn other symptoms of anxiety as well. So we are talking about the symptoms of anxiety that when somebody is coming across a threat, somebody is coming across a triggering factor for anxiety, how is to be appreciated, how is to be diagnosed, what are the clinical features. So we talk about the clinical features of cardiovascular symptoms, genital urinary symptoms. We talked about the going back, hyperventilation, sleep, arousal, muscle tensions. And the list is again not complete because we have to include the central nervous system as well, and headaches, sort of weaknesses, sort of paresis, sort of anesthesias, sort of paresthesias. These all could be symptoms of anxiety. And again, let me emphasize again that for the first time, if the patient is coming with any of these symptoms, it is not my recommendation to label the patient as a patient of anxiety. But please investigate the patient, but to a logical extent. And logical extent means that do not over-investigate the patient. If the age is not appropriate for that particular thing, give more stress for the clinical examination, give more stress on the history taking, just to avoid over-investigating, just to avoid, because all the over-investigating, when you are over-investigating a patient, it basically reinforces the symptoms of anxiety. And what do I mean by reinforcement? Perhaps anything which increases the chances of further repetition of that particular response is reinforcement. So if every time you are subjecting the patient to a new drug, to a new investigation, you are basically subjecting the patient to further increase in the response of that particular region of symptoms. Now, what triggers anxiety? Threat and conflict. In a way, you can say that these are only two words, threat and conflict. But this is a whole world for a psychiatrist. You know, when we talk about the stress, anybody can pinpoint that, look, this is the stress. Somebody is ill, somebody is having say for example, COVID in this environment, somebody's parent is ghastly ill, there's a big loss in the business, no opportunity for a job, and blah, blah, blah. Is stress visible? But here, the threat and the conflict, which are residing inside the body, inside the brain, in the unconscious brain, and when there is some threat, some perceived threat, which is only visible to you perhaps because it is non-specific, or there is some internal conflict, that triggers anxiety. By and large, the symptoms of stress could be the same. A man who is in stress can be coughing. A man who is in stress can report to the medical authorities with palpitation or some rise in blood pressure. But a man with conflict, he will report with the same symptoms, but he does not know. Neither he knows nor his doctor knows that what is exactly the conflict, but there is some conflict. So these are the triggering points that why a man becomes anxious all of a sudden. After knowing all these symptoms, I have to be a little fast. We have to classify the anxiety disorders. And by and large, there are three major classes of anxiety disorders: generalized anxiety disorders, panic disorders, and phobic disorders. Now, in this single slide, you can identify all these three disorders with 2 or 3 conceptual points in mind. If the symptoms which I mentioned earlier in my earlier slides are present for most of the time, for most of the days, for most of the weeks, it's a generalized anxiety disorder. If the symptoms are coming in episodes, not almost every time, then for these episodes, there are 2 possibilities. One, episode is coming with a stimulus. Episode is coming without a stimulus. If it is coming without a stimulus, it is a panic disorder. If it is coming with a stimulus, it's a phobic disorder. Phobia, you know that. I'm phobic to this, I'm phobic to that. So that is stimulus. All the anxiety, symptoms are there. And by no means I mean that every anxiety patient should have all those set of symptoms present in order to diagnose anxiety. No. Some few pick up few GIT symptoms, few pick up cardiovascular symptoms. It depends upon their own knowledge and background and so forth, so on and so forth. But whatever the set of symptoms they have learned, if they are coming in with a stimulus, it is a phobic disorder. Without stimulus, it's a panic disorder. Few words about GAD, generalized anxiety disorders. Pale face, tense posture, this is the clinical presentation, no obvious reason, 4 to 5% is the prevalence. Same anxiety symptoms, but stimulus is there. Mostly stimulus could be an animal or a situation or some illness or treatment, like dental chair treatments are not very famous. Phobia, dental chair, phobia of dental chair. Common in women, 70% in comparison to men, 7%. Panic disorder symptoms are same but episodic. No stimulus is found. A man is standing in a bus stop or on the roadside, and all of a sudden he gets panic. And just because of that panic, he has to be taken to a hospital. Prevalence is about 4%. Twice common in females. Anxiety builds up quickly. Symptoms are severe, and fear of serious outcome are common. And when we talk about the serious outcome, mostly we are talking about the heart attack. Hyperventilation is again, and especially in youngsters, and especially in young females, because by and large, most of the anxiety symptoms, most of the anxiety disorders are far more common in females in comparison to males. So hyperventilation, typical hyperventilation attack is comprising tachypnea, dizziness, headache, feeling of weakness, and all the myocardial discomfort. As a result of all these things, tachypnea and fast breathing, shallow breathing, start tingling in the hands, and tingling in the hand later, there are certain biochemical changes in the brain in the form of some proteinous changes, carboplatin spasm, tetany, and that can end up into convulsions and fits, and fit, somebody having a fit, aspiration, and you know what could be the complications of aspiration. 2 additional varieties you must have in your mind. Quite common these days, social phobias or social anxiety disorder. Symptoms are same, but triggering factor is that when you face public, some presentation, you want to address some people, you want to confront somebody who's interviewing you, some superior one, blushing and trembling and prominent, you're not able to answer him properly, social anxiety disorder. And anxiety disorders, agoraphobia, symptoms, same again, same means that symptoms of anxiety in situations difficult to escape from. A very important word, a very important sentence. In situations difficult to escape from or away from home, or one feels confined, lifts, aeroplanes, closed spaces, from where the patient feels that if somebody would happen, he would not be able to manage escape. This is agoraphobia, again, not very uncommon. So far we have seen that anxiety disorder mostly, and Most of the anxiety disorders are much more common in females. I hope that a small slide for etiology. They run in families. Stressful events are important in etiology. Early life experiences are important. Learning, conditioning means learning. If somebody learn from somebody else, this is important in etiology. Cognitive dysfunctions mean that there are people who give importance to the very trivial details of the body functions, very small pains, very small, say some changes in the body, some changes in the GIT. Say, for example, if somebody has taken a big bulk of food and some bloating, he will immediately come to the conclusion something wrong with him. So this is what I mean with the cognitive dysfunction. People, you can say in layman word, the people are oversensitive. So these are few points in the etiology. Etiology needs to be discussed in much more detail, but not at this level. The management. The very important thing when we're talking about the generalized anxiety disorder, a good rapport should be established with the patient. You know, these are anxious patients. And with anxious patient, you need to have some time to be spent with them. And what you will do out of that time, you will let the patient explain that, look, the pain is there, but you had been investigating sufficiently. We had been investigating sufficiently from the cardiac point of view, and considering your age, considering everything is normal, it does not mean that you are not suffering from anything, but you are suffering from anxiety disorder. Because you know what about most of the doctors commit a mistake, that when they come across a patients and they let the patient undergo a lot many investigations, and when all investigations come normal, they say a very wrong word and sentence to the patient that, look, your all tests are normal, you're fine, nothing wrong with you. So this last sentence is a big insult to the patient who is coming to you every now and then. You have to let him know that fine, your all investigations are fine, means that your heart is working well, your lungs is working well, but you are suffering from anxiety disorder, which is a known entity, which is a known illness. This is what I mean by establishing a good rapport. You will not dismiss the patient as such because they're saying that you are not suffering from, or you do not have anything. Brief the patient about the nature of illness and psychotherapies and behavioral techniques. Medicines have a role, but a limited role. I mean, not limited role, but the psychotherapy has an equivalent role in cases of the management of anxiety disorders. Benzodiazepines we use for a small span of time because they are addictive drugs, sedating drugs. Then selective serotonin and reuptake inhibitors for long-term use. These patients do improve, very significant improvement if you treat them effectively. Paroxetine is a long-term management. It is diazepam 5 milligram, few doses. By now, I think that you know that what is generalized anxiety disorder. And now I will switch on to the obsessive compulsive disorder. By now, I think most of you understand the anxiety spectrum. Can you raise your hands that everybody has understood? Good. So I can see a good number of hands who understood the anxiety disorder, which I took about 25 years to understand. Thank you. Good. Okay. Obsessive compulsive disorder. Most of the books discuss this chapter of anxiety disorders because anxiety is one of the main features, but in a different way. And what is that different way? I will explain in the next slide. Prevalence is about 2%, and this is one of the, but rather the only anxiety disorder which is more common in males. The rest of all the anxiety disorders are much more common, much more frequent in females, but this is twice more common in males. Now, what is obsession? It is a thought, one. It's a repeated thought. Bar aa rahi hai. And the patient has full awareness that this thought is his own thought, unlike the thoughts and session of schizophrenic patients. Third or fourth, that the patient knows that this thought is not logical. And since he knows that this thought is not logical, so he tends to resist. And failing to resist develops anxiety. So look at the sequence. This is a thought which is coming repeatedly. And the patient is aware that this is his own thought, and at the same time he knows that this thought is illogical. And I will let you know that what does it mean. And since he knows that this is logical, he tends to get away from this thought, but failing which develops anxiety. When these thoughts are converted into acts, that's called compulsion. Again, repeated resistance, anxiety, and all that. Now, what do I mean by logical? So, for example, if somebody is having OCD, obsessive compulsive disorder, he touches a mic and he starts feeling that this mic was dirty and he should wash his hand. And he knows this mic is not dirty. And he can see, he can look at his hand, this hand is not dirty. There's no dust on his hand. So this thought that his hand is dirty is illogical. And he's trying to resist that thought that this is illogical, and failing to which he develops anxiety. And as a result of which he goes to the washroom and washes his hand. That becomes motor act. Examples of words, ideas, beliefs, ruminations, impulses, rituals, slowness, phobias. Now, these are the few presentations of certain ideas come roaming into our mind. We have certain beliefs which have nothing, nothing logical in it. Certain rituals, certain debates which are going into our minds. Certain rituals, and one of the example of ritual that in our purses we have to keep the currency notes in a particular fashion, all upside down and like this, and absolute painful sort of orderliness, examples of OCD. And what will ultimately make you slow? It will ultimately make you slow. Because if you are going to spend a lot of time in spending rituals and ruminations and making the things clean and immaculate, then you will become slow. So these are a few examples of when you will come to our wards for clinical teaching, you will be in a more we will be more comfortable in letting you know the definitions and specific meanings of these words. Etiology, genetics in anxiety, genetics here, but in OCD, the evidence of brain disorder in some early part of the life, like encephalitis or some other space-occupying lesion, and there's an abnormal serotonin function. Psychoanalytic theories are also there. You can go to your books, consult your books to come to know that what is a psychoanalytic theory. But ultimately, what is the ultimate how the symptoms build up because of the abnormal serotonin function, whether it is genetics or the brain disorder or psychoanalytic theory, but the manifestation of symptoms come from that deficiency of serotonin. Again, the management reassurance, and reassurance means that this is an illness. Most of the people think that this is something sinful which had happened on this is the result of because there's sinful activity, or they are being punished by the God, or they become mad, or they would become sort of kafir because so many obscene ideas are coming into their mind. We talk about the ideas and beliefs. So reassurance that this is an illness. This is an illness. It will not make you mad. It will not make you a disbeliever. And then behavioral techniques like thought stopping, desensitization, these are more technical words. I'm not going to explain right now, but you can go through your books, and whenever you come to our ward, we will in detail let you know, for your consumption, because most of you are not going to become psychiatrists, but some sort of thought stopping, some sort of desensitization. Why? Because OCD and GAD patients, normally they do not land up with the psychiatrist. And they are roaming about with the rheumatologist, with the cardiologist, with the pulmonologist, the gastroenterologist. So, and most of you are going to become from the discipline other than psychiatry. So these small things you should know better than anybody else. Medicines, that clomipramine was once upon a time the drug of choice. SSRIs, again, you know, we talked about in the early part of this lecture. Clomipramine, 100 milligram at bedtime for a long-term management. Paroxetine is one of the SSRI which we use for days 20 to 40 milligram once daily. And for a short span of time, we can also use anxiolytics, but anxiolytics, again, not an answer for anxiety disorders because of their addiction, because of their sedation, because of their, most of the time, they're having long life. I'm very thankful for a very patient listening on a very beautiful rainy day that you must be waiting for to enjoy. Thank you.